I'm Dr. Lauren Beretich, and today I'd like to review with you an article titled Diagnostic and Clinical Utility of Genetic Testing in Children with Kidney Failure by Chen et al. This article was published in Pediatric Nephrology online in May of 2021. The investigators were from multiple departments from Fudan University, including the Department of Nephrology, the Clinical Genetics Center, and the Key Laboratory of Metabolism and Molecular Medicine. The etiology of kidney failure in children varies from that in adults. Per the 2018 report of the North American Pediatric Renal Transplant Cooperative Study, in children oftentimes kidney failure is related to CACT, congenital abnormalities of the kidney or urinary tract, or steroid-resistant nephrotic syndrome. The authors also mention that genetic testing might increase CKD or kidney failure diagnostic accuracy. But the utility of genetic testing in pediatric patients with kidney failure is not well described. One previous study by Chen et al. In 2019 reported a diagnostic yield of about 32.7%. The aim of this study was to determine the diagnostic yield and clinical impact of genetic testing for children with kidney failure. Patients were included in this study if they were seen at Children's Hospital of Fudan University from January 2009 to December 2018. These individuals also all had kidney failure before 19 years of age and had NGS or next generation sequencing results. All participants were seen by a genetic counselor at the time of testing, and a 3-generation family history was obtained and a pedigree was created. The clinical diagnosis of kidney failure was categorized for each participant into one of the 6 categories, either CACT, steroid-resistant nephrotic syndrome, chronic glomerulonephritis, ciliopathy, nephrolithiasis, or kidney failure of unknown etiology. The type of genetic testing varied by participant. Some participants had targeted exome sequencing, others had proband whole exome sequencing, and others had trio whole exome sequencing, where the proband and 2 additional relatives were tested. The type of testing did vary based on the patient's personal and family history. In total, there were 188 participants from 188 independent families. 55.3% of participants were males, 3.2% of participants were from consanguineous families, 18.1% of participants had a family history of kidney disease, and 28.7% of participants had extrarenal manifestations. In total, the diagnostic yield in this cohort was approximately 40%, and 8 genes accounted for 64% of patients. Those 8 genes are detailed below to the left and include WT1, CoQ8B, NPHP1, PAX2, NPHP3, COL4A5, AGXT, and NPHS2. If you look over to the right, this is looking at those disease categories that we discussed and looking at how many were considered solved, where we did identify genetic diagnosis, versus unsolved, where we did not identify genetic diagnosis. And this varied based on disease category, with nephrolithiasis having 100% solved cases, and of course varying by each specific category. The authors also detailed the diagnostic and clinical utility of genetic testing in this population. The diagnostic utility included a confirmed clinical diagnosis, being able to pinpoint specific subtypes, reclassifying a diagnosis, or clarifying a diagnosis for an individual with unknown etiology. Clinical utility included negating the need for a biopsy, avoiding immunosuppressive therapy, guiding treatment in other ways, improving follow-up surveillance, influencing transplantation management, and last but certainly not least, guiding cascade testing. Overall, genetic testing in this cohort identified a high diagnostic yield of 39.9%. Extrarenal manifestations were associated with the genetic diagnosis, but in this cohort, consanguinity and a family history were not, while these are traditional risk factors for genetic disease. At this time, more research is needed to better understand the genotype-phenotype associations presented and to use larger cohorts to study the yield and utility of genetic testing for children with kidney failure. In conclusion, genetic testing aided in diagnosing children with kidney failure in this cohort, and there was a quantifiable impact on patient management. Thus, one may argue this data supports the routine use of genetic testing for children with kidney failure. Thank you for your attention. And for any questions about renal genetics, please don't hesitate to reach out to the medical education team at Natera.